Hello, my name is Roy Shork. I want to thank you on behalf of my colleagues Deirdre Corey, Lee Griffin, Jose Jimenez, and Jenna Massey for sitting in our presentation today regarding wrong site, wrong procedure, wrong patient errors. Why are they still occurring and what can be done about it? In this presentation, we will share a brief history of what WSPEs are, regulatory mandates created to reduce the number of WSPEs, and analysis of WSPE related to court cases, the compliance failures that contributed to those errors, and how the information can be utilized in creating a best practice approach to preventing future events. You can see from this side that wrong site surgeries have a long history and that they are nothing new. Since 1947 through the current times, wrong site surgeries have shocked those involved, and you can see some examples here on this graph. For example, in 1947, there was a report of somebody having the wrong eye removed. In 1995, the wrong leg was amputated, which resulted in a $1.15 million award. And then in 2015, surgeons operated on the wrong side of the brain, settled out of court, and the surgeon faced disciplinary action. So wrong side surgeries have a long history, and they continue to happen up to the present day. In response to the number of medical errors that were occurring, the Institute of Medicine, or the IOM, released To Err is Human, Building a Safer Health System in 1999. This report shared that approximately 98,000 deaths in the United States were caused by medical errors annually. The initial result was defensive posturing from healthcare organizations who felt that the IOM was blaming the errors on individuals, but the true intent of the IOM was to emphasize that errors were not the results of incompetence or recklessness, but rather from faulty processes that failed to recognize potential harm and prevent it from occurring. A sentinel event is an occurrence that requires an immediate response and results in death, permanent harm, or severe temporary harm that requires interventions to sustain life. 1996, Joint Commission adopts Sentinel Event Policy, which strongly encouraged reporting on sentinel events, increased the transparency and promoted culture of safety, and sends a message to the public that we are doing everything we can to increase patient safety. In 2001, the National Quality Forum introduced the term never event to describe events that are shocking and should never happen. These events are usually preventable, clearly recognizable, and measurable. Again, healthcare organizations were encouraged but not mandated to report. By 2009, 867 wrong site surgeries were reported and comprised the largest percentage of all reported events at 13.5%. Today, a little over half of the states have mandatory reporting, and reporting policies vary greatly, and only a small portion report publicly. So why is it that 20 plus years after wrong site surgeries were recognized as sentinel and never events, they are still occurring at an alarming rate? Well, our research presents critical overview of the universal protocols, real-world examples of never events, effective root cause analysis to create proactive action plans, and recommendations for compliance leadership roles in reducing WSPE risks. In 2004, the Joint Commission, also known as JCAHO, enacted the Universal Protocol to address this growing concern that sentinel never events were still occurring. It is not enough to implement measures to prevent errors. A healthcare organization must have a compliance program that ensures that all staff receive adequate training on pre-procedure protocols and that the protocols are followed for every procedure. The universal protocols include timeout procedures for verification of correct patient, correct procedure ordered, and correct body part. Verifying directly with the patient the name of the patient, date of birth, and that the procedure site marked topically and visibly is correct. And also having the provider and entire team openly state the procedure to confirm what is being done with all members of the team and patient. If despite these protocols a wrong site surgery occurs, the healthcare organization must perform a root cause analysis and report results along with the error to JCAHO. This is a recent incident of a wrong site surgery and it is a perfect example of how it could have been prevented by taking simple measures in implementing the Joint Commission's recommended protocol. In 2013, a woman successfully sued Lancaster Neuroscience and Spine Associates and the Neurospine Center, as well as a physician and nurse, for performing spinal surgery on the wrong spinal discs, resulting in removal of a disc that had been healthy prior to the surgery. According to the court document, the spinal clinics were aware that the proper procedures for the avoidance of wrong site surgeries were not in place and knew the risk of harm to patients and knowingly allowed the surgery to proceed. Based on this, they had not implemented any protocol to ensure compliance with the Joint Commission rules, exposing their organization to massive financial risk. This case is a great example of how important it is for hospitals and clinics to implement a compliance protocol in order to prevent instances of wrong site surgery, as the risk to the patient and thus financial risk to the organization is huge. Here's a 2014 case between Mercado versus Burlett, and it is an example of a wrong site surgery, where there appears to have been protocols in place to prevent it. However, protocols were not followed and documents were falsified in an effort to conceal the mistake. According to court documents, prior to the surgery, the patient Chloe Mercado and the surgeon Gregory Burlett met and both signed a consent form to perform surgery on her right foot. This exercise appears to follow the Joint Commission's recommendation to involve the patient in preoperative verification of important details. However, as the court case outlines, a different surgeon performed the procedure on her left foot. The court case also mentions that an operative report was filed out by Bartlett after surgery, the purpose of which is to accurately record the procedures that had been performed, where he failed to mention that the procedure was done on the wrong site and that it was performed by a different surgeon. This case is a perfect example of the importance of diligently following protocols after they are implemented in order to perform effectively and reduce risk to the patient and the organization. In this case, a 15-year-old, Cody Matheny, underwent elective brain surgery at Arkansas Children's Hospital to correct epileptic seizures on the right side of his brain. Prior to the surgery, the patient's mother consented for ACH to allow a reporter to observe and record the procedure. According to court documents, the surgeon, Dr. Adada, cut the left side of the brain and damaged significant parts of the left side, and after realizing the mistake, continued to operate on the right side. Following the surgery, Dr. Adada informed the Methanys of the mistake, however assured them that no harm was done. 15 months after the surgery, when Cody began to have difficulty expressing emotions, the Methanys were informed that tissue from the left side of the brain was removed, a fact that was not made clear to them prior. According to a nurse's testimony, the team followed preoperative procedure but did not know which side the surgery was supposed to be conducted on until after the mistake. Further, according to court documents, Dr. Adada also testified stating that although this mistake was a sentinel event, the procedures that followed after such an event were not conducted. Based on the surgeon's testimony, he agrees that this was a sentinel event, which would require investigation and analysis. However, this procedure was not followed. This displays another major lapse in compliance procedures if they are not adequately following protocol and reporting sentinel events. This slide breaks down the process for root cause analysis. Root cause analysis are increasingly being used proactively and not just retrospectively. They fully identify and understand root causes as a basis for designing a better approach. The root cause analysis goal is to produce an action plan with intended strategies to reduce risk in the future. Root cause analysis critically reviews the entire process and support systems, effectively identifies sentinel events, causes, and contributing factors, and implements risk reduction strategies, and determines effective, efficient ways to measure performance. This slide has an interesting graphic that illustrates the systematic approach to preventing adverse events. And what we have here is the Swiss cheese model of adverse events. An adverse event can only happen when the holes or failures are perfectly aligned. Multiple layers of barriers, defenses, and safeguards are necessary to prevent an adverse event. High risk, low incidence industries such as nuclear power build in significant redundancies of safeguards to prevent adverse events. Healthcare is learning from this model to proactively prevent sentinel events. The role of the Chief Compliance Officer is key in the development of an effective program to eradicate WSPEs. However, it is important to remember that it is not the duty of the Compliance Officer to be directly involved in the day-to-day operations of running the surgical department. The CCO should remain within reason an external and independent entity that provides a comprehensive and frequent auditing and monitoring function in post-op reviews. Failures that lead to WSPEs can occur within the areas of scheduling, pre-op holding, within the operating room, and as a result of defects within the organization's culture. The CCO must develop effective and meaningful communication with the corresponding management teams of these areas and secure buy-ins as to the importance and necessity of following strict protocol. The CCO's role may vary in particulars according to the healthcare setting, but generally speaking, it should ensure that all staff receive adequate, updated training on pre-procedure protocols, provide RCA support and leadership, and through a comprehensive process of auditing and monitoring, ensure that the protocols are followed for every procedure. And now we would like to present our specific recommendations, our 15 recommendations to help make WSPEs a thing of the past. For the sake of time, we won't be able to go into much detail, but here is the outline of our basic recommendations. First of all, join a patient safety organization. A PSO facilitates learning from previous errors and supports a change to a culture of safety without opening the organization up to perceived risk of public non-confidential reporting. Next, we have consistently comply with universal protocols. Thirdly, we have ensure compliance department is part of the Sentinel event policy team. The compliance department is uniquely situated to provide big picture analysis as well as detailed monitoring and auditing of the organization's Sentinel event policies and should be a valued resource in the eradication of WSPEs. Fourth, we have identify standard taxonomy for reporting patient safety issues. This is to be utilized in interdepartmental meetings. This will facilitate the collection, analysis, and trending of data across all areas. It also allows closer examination of human and process roles in medical errors, identifies potential areas of risk, and promotes safety initiatives based on previous outcomes. And number 5, we have perform annual reviews to ensure Sentinel event policy is in compliance based on data-driven change. Perform processes that help identify error with basic data collection and potential human error data entry that could have detrimental effect to the patient. Okay, here are our 6 through 10 recommendations. First off, we have promote a leadership culture with shared governance. Upholding a culture of transparency, integrity, and responsibility are fundamental to reducing and minimizing errors. The practice of a daily huddle, where all members of the leadership, the health providers, and the staff report any potential safety harms to the patient and employees, is extremely important. Number 7, we have promote a just culture. A just culture refers to an environment in which accountability is balanced between the HCOs and the individuals. Number 8, we have implement and support policy of no practitioner hierarchy in the operating room. The policy should promote zero tolerance for bullying and intimidation and have a no retaliation policy for reporting instances of hierarchy bullying. Number 9, we have make a copy of Sentinel event policy available to patients upon request. This practice is supported by Leapfrog. Doing so promotes transparency and accountability on the part of the hospital. And number 10, we have appropriately conduct a root cause analysis of how and why the event occurred. The RCA process, as required by JCAHO, must be followed carefully to ensure proper analysis and resulting corrective action. Okay, now we have our last 5. And number 11 is pretty straightforward. It's have a clear corrective action and discipline policy in place and have all the employees know exactly what it consists of. Number 12 is require instant accountability. In order to address the culture and team dynamics of accountability, every member of the surgical and procedural team should be required to agree or disagree with the procedure. This model is practiced in many HRO industries, from NASA to the military command and aircraft carriers, similar high-risk industries where precision, high risk of harm, death, and timing are very narrow. Number 13, we have two-phase mandatory debriefing following a never event. Employees involved in a never event can experience stress that ranges from short-term that self-resolves to serious post-traumatic stress disorder. Phase 1 is immediate emotional support, and Phase 2 is analyze and learning from the event. Both phases are equally important. 14 is waive all costs related to the event and follow-up care. It is inherently wrong to charge a patient for a procedure that results in a WSPE and will help serve as a deterrent for future events. Even if the patient is a private insurance or paid out of pocket, they should receive the same treatment. And lastly, number 15, apologize to the patient and family. In the event of a WSPE has occurred, the offending institution should immediately provide transparency and support to the patient and their family, as well as inform the patient and family of the actions that the hospital will take to prevent future occurrences of similar events based on the findings from the root cause analysis. The organization should act quickly to investigate and own its mistake so that the process of mediation can begin. Okay, in conclusion, and to sum up this presentation, WSPEs still occur at an unacceptable rate. This indicates a breakdown in compliance institutional functioning. The impact on both patients and institutions can be devastating. The CCO, board, senior, and department management are all integral to finding a solution to these events and preventing them from happening in the future. The 15 recommendations will minimize the risk of WSPEs. Successful implementation of the recommendations will aid in the overriding pursuit of compliance, organizational integrity, patient safety, and trust. This slide breaks down our research limitations that were experienced and the future research potential in the industry. Our limitations were poor data due to underreporting and inconsistent categorization, lack of expertise regarding WSPEs and management aspects of sentinel events, lack of access to internal documents and information. And future research may be in the analyzation of data as sentinel event reporting improves, review private surgery center data, which currently is not required to report, research which states have mandated sentinel event reporting and impact of mandated reporting on number of sentinel events, and the implications of False Claims Act's STIC potential for reducing WSPE events. Slides 18 through 24 consist of our valued resources. I would like to thank my team members for all of the hard work that they put into this final project. Thank you.